Good afternoon and welcome everyone. Thank you for joining us today for the webinar hosted by Deepas. Today we are having an experience sharing session by Dr. Deepika Chenna, Associate Professor, Department of Immunohematology and Blood Transfusion, Kasturba Hospital Medical Center, Blood Center, Manipal, on rare blood donor registry. This session will be chaired by Dr. Mayadevi S. Dr. Mayadevi is a distinguished professional with an illustrious career in the medical field. She currently serves as a professor and head director at the Model Blood Center, State Nodal Center, Government Medical College, Trivandrum, Kerala. She has 30 years of teaching experience in government medical colleges in Kerala. She has been a faculty member of MD Transfusion Medicine for 23 years and has made significant contribution by establishing a molecular lab, rare donor registry, and implementing automation in the blood bank. Her expertise is recognized through her membership in the Board of Studies at PUHAS and her role as both external and internal examiner for the MD Transfusion Medicine. Dr. Mayadevi has also contributed to the academic community with 10 publications in index journals. Her remarkable achievements have been honored with several awards, including Appreciation Award for Liver Transplantation Program in 2022, a Lifetime Achievement Award from KEBS in 2022, the Jeevan Raksha Award from Anti-Narcotic Action Council India, and Sri Ratna Award from Anti-Narcotic Action Council India in 2023. Over to you, ma'am.
Thank you. Thank you for the organizers. I may thank the organizers of TEAMers for inviting me to chair this session. And I am happy to introduce. She is Associate Professor in Kasturba Medical College. And she is a member of ATOM and reviewer of various national and international journals of organized various workshops and CMEs at state and national levels. And we are fortunate to get her as the speaker. And her areas of interest are immunohematology, FRSs, clinical chemotherapy, and rare blood donor registry, of course. And she has got many awards from Indian Society of Transfusion Medicine, ISTM, for Postgraduate Student Award in 2014. And ABB Atom International Fellowship Award in 2023. And she has done a platelet PRP, platelet-rich fibrin group preparations, and as the copyright registered, so also in the quality control of blood collection monitor patents. And she has more than 35 publications in index journals. Welcome. Welcome to
Thank you, ma'am. Thank you for the introduction. Am I audible?
Yes.
Yeah. I'll start sharing my screen now. Is it visible? Is the screen visible? Shall I start?
Yes, of course.
Yeah. Okay. Yeah. So first of all, I would like to thank Dr. Maya ma'am and the Transfusion Medicine Academic Society for giving me this opportunity to share our experience actually and about the rare blood donor registry. So in the next 30 to 40 minutes, I'll be covering about the rare blood donor registry under the following aspects, like a brief background, how do we define a rare donor, and what happens at the International Rare Donor Program, and various national level rare donor programs, what are happening, the Indian scenario and the challenges we face, and a brief note on our experience. So to begin with, let us discuss with a case, because we always have cases only to as a support for our literature. So it is we received a 45-year-old male admitted at the emergency with an alleged history of road traffic accident. He had a fractured femur for which a surgery was planned and the transfusion request was received at our center. His blood group was BRHD positive without any discrepancy, and the cross matches were incompatible. This is when we proceeded further with our immunohematological workup, where we saw a pan reactivity with all the antibody screening cells and the identification panel with a negative autocontrol. So our first query here, we generally don't jump directly to antibody against it. So we generally do not jump directly to an antibody against high frequency antigen, but however, we always try to see whether there is any in vitro reaction which is causing this kind of reaction, like antibody against a preservative or antibody against the less or antibody against the column. So after ruling out all these possibilities, only then we could identify that it is possibly an antibody against high frequency antigen. But we are helpless here where we could not identify what antibody it was. So our first thing what we did was inform the clinician about the rare phenotype and the immediate non-availability of blood for the surgery. So the clinical team was well communicated, they understood, and they postponed the surgery. They have done other PBM strategies like recombinant erythropoietin usage and iron supplements to build up the hemoglobin before performing the surgery. Meanwhile, the patient samples were sent to an international reference laboratory where at a later date, we could identify that it was the rare penal phenotype. So this is how we identified an antibody against a high frequency antigen, which is naturally occurring as well. So generally, when do we identify these antibodies? So as a part of routine pre-transfusion testing, as we have seen in this case, and sometimes in antenatal women as a part of antibody screening, or when the baby develops hemolytic disease of fetus or newborn, or when we see blood group discrepancies, or among donors when we perform the antibody screening, like the anti-H, which occurs as a naturally occurring antibody, or the anti-P, P1, PK in the penal phenotype. So if you look at the ISBT nomenclature, there are about 45 blood group systems identified till date with more than 200 blood group antigens which are expressed throughout the red cell membrane. We also have blood collections, the 200 series, and the low and high incidence antigens, that is the 700 and the 901 series. So low incidence antigens where the frequency is less than 1% and high incidence is when it is more than 90%, when the incidence is more than 90%. So with so many antigens that are present, we have different phenotypes for each individual. So when a patient is sensitized, there can be alloantibodies, or based on the phenotype, there can be a common or a rare phenotype. So do all the antibodies that are produced in an individual are clinically significant? How do we define a clinical significance? So a clinically significant antibody is one where it can cause a decreased survival or an increased destruction of the red cells. It may lead to hemolytic transfusion reaction or the hemolytic disease of fetus and newborn. So this clinical significance of an antibody is dependent on many other factors like the antigen immunogenicity, the frequency with which the antigen occurs in the population, and some of the antibody characteristics like what is the specificity of the antibody, the phase and strength at which it reacts, the titer for the level of antibody in the serum, the subtype, the immunoglobulin subtype of the antibody, and whether it can bind to the complement in vitro to cause hemolysis. So based on all these factors, if we take into account, not all the antibodies are clinically significant. So how do we determine this clinical significance? we have some assays which help in determining the in vivo clinical significance of an antibody. So these are radio-labeled chromium-based assays or the biological cross-match where 20 ml of antigen positive unit is transfused to a patient and is monitored for any signs of hemolysis. But in both these cases, we need to transfuse the patient and take the risk of having a chance of hemolysis. But if we look at another test called the monocyte monolayer assay, this is an in vitro assay, though TDS, but it can help in predicting the in vivo clinical significance. However, it is available only at some of the reference laboratories as of now, and it plays a major role in decision making in patients who have these rare phenotypes. So now, if we look at the rate of alloimmunization in transfusion recipients across the world, it ranged from as low as 0.23% to as high as 55%. So it is not unlikely that patients can develop multiple antibodies as well. And in such cases, again, the provision of phenotype matched blood might be difficult. So all these are some of the causes for the rare phenotypes. So how do we define a rare blood donor? So a rare donor is defined as a person who lacks a high frequency antigen or is negative for multiple common antigens. The American Rare Donor Program also includes IgA deficient individuals to be considered as rare donors. So how do we define a high frequency antigen? So when the occurrence of the phenotype is less than 1 in 1000, it is considered rare, or when it is less than 1 in 10,000, it is considered very rare. However, these are not uniform across all the countries, and each country has its own definition for rare blood donor. In France and Switzerland, the rare phenotype is described as 4 in 1000 or 1 in 250 individuals. In USA and Spain, it is 1 in 1000. In Netherlands and UK, it is less than 1 in 100. And the Japanese Red Cross have two different categories, which we'll discuss later again. So coming to individuals who are negative for multiple common antigens, why are they also considered rare donors? Suppose if we take, this is from a study from French population, where they have seen that if an individual is K negative in their population based on the frequency, it is 1 in 350 to 1 in 700. Now, they needed a patient with an R1 phenotype who developed anti-Dept. So when they had to look for a donor, the frequency had come down so low that the patient is A negative with the R1 phenotype and Dept negative. If we take all these into account, the prevalence comes down to as low as 1 in 5,000 to 1 in 10,000. So even these patients or individuals are considered to have rare phenotypes. Now, why is there increasing demand for this rare blood? This is mainly because of the immigration, the global migration, leading to increasing ethnic diversity. And also, in most of the patients, now chronically transfusion dependent patients, the use of precise matching, that is, matching for the extended antigen type of the patient, is also increasing the demand for the rare blood. And also the newly coming up monoclonal antibodies, which interfere with our pre-transfusion testing. And we do not have any other mode to remove this interference. In such case also, we need to give a precise matched, antigen matched blood. So there is an increasing demand for the rare blood units. Now, if we talk about the ethnicity, this plays a very crucial role in understanding the prevalence. If we take the simple D antigen, in Caucasians, it is around 15%, but in Asians, it is approximately only 1%, and in Indians, it is approximately 5%. So similarly, each antigen prevalence varies across different ethnicities. If we take the well negative, it is around 1 in 4,000 in most of the people, but in Sweden and Norway, it is a slightly higher with a prevalence of 1 in 1,700. The KID3 phenotype is more common in Finland and Japan, and the U negative and the JSP negative are more common in Africans. So when we are looking for a specific phenotype, we need to understand where the specific particular phenotype is common in which ethnicity also. Thus, this will give us a more predictive approach in identifying a rare donor. So how do we identify these phenotypes? So mostly it is based on the monoclonal antibodies, our reagent antisera, and also the serum from patients who developed these antibodies. Then we can even do molecular genotyping. And once an index case is identified, it is always good to perform the family studies to identify rare donors in the siblings or other members of the family. So genotyping is considered more advantageous because it is simple and straightforward, and it is just a single nucleotide polymorphism which causes the difference in antigen expression. So if we can establish a high throughput genotyping, this is more useful for identifying a rare phenotype. So after identification, we need to confirm the specificity at a regional or national reference laboratory, type for all the remaining significant antigens, and we need to take a consent from the donor as well to be a part of the registry. And if he has already donated, whether the blood is to be stored in a liquid or frozen state. And then if it is in frozen state, some countries have a policy to store up to 10 years. Some countries store even up to 30 years or longer. And after thawing, the cryoprotectant should be removed. And if an open system is used, it can be used only up to 24 hours. And when a closed system is used, it can be used up to 1 week. So what is the role of reference laboratories in these cases? They help us in identification of challenging alloantibodies to differentiate between auto from alloantibodies. They have the availability of most of the rare antisera genotyping facilities. They provide training and education in identification of these rare phenotypes and also help us in contacting international registries for further support. So now coming to the timeline of the rare donor programs. It started way back in 1964. The International Rare Donor Panel was started in collaboration with WHO in 1964 and is maintained by the IBGRL at London. The American Rare Donor File program has started in 1959 and the American Rare Donor Program was started in 1963, and both of these were merged and functional since 1988. So what is the role of ISBT Working Party on these rare donors? So this was conceptualized in the year 1984 and is established in the year 1985 with the main aim to increase the number of donors in the International Rare Donor Program and to have a better communication between the members of these rare donor programs at national level. So in a nutshell, their function is to mainly bring together the members involved in the rare donor program, act as a resource of information on issues related to rare blood, collaborate with the International Rare Donor Program, and to facilitate with the IBGRL to maintain the database of these rare donors, increase the number of rare donors, promote and facilitate education related to the rare donor program, and they also provide recommendations about the standardized testing, listing, and shipping of the blood. So these are the different countries across the world which are under the ISBT Rare Donor Working Party. And if we take Asia, there are 6 countries which are involved in the ISBT Working Party. That is Japan, Taiwan, Singapore, China, Iran, and Israel. So the IRDP, as already told, it is maintained by the IBGRL at Bristol. And they have a very rare phenotypes. The rarest phenotype which they have is Rh null, with only 12 donors identified till date, and the D following which the D negative K null phenotype being the next. So the IRDP manages only data related to donors lacking the high incidence antigen, but they do not maintain the list of individuals who are negative for multiple common antigens. So the first edition was started in 1968 with only 300 donors from 10 countries, but currently they have around 15,000 donors from 30 countries. So this is their website, and we can request through email with the following ID related to access. So these are different countries which are under the ISBT Rare Donor Working Party. They have listed for each country what is the definition for a rare donor, how many active donors they have, how many red cell units are available, and how many times they have shipped, how many requests. All these were compiled in this article. And this is the number of donors which with rare phenotypes. If you can see, there are some phenotypes with more than 1,000 donors registered, and there are some very rare phenotypes with only in single digits, like the Rh null, Colton, INB, negative, etc. So coming to the American Rare Donor Program, this has around 90 member facilities, of which 87 are in the United States. And to become a ARDP member, then they select members who are working in blood centers, working as immunohematology reference laboratories only. And to become a reference laboratory, they have strict criteria, or they should be accredited through the ABB. Like they should have some of the criteria what they have defined are like they should have at least 10 donors that are registered in the database, or at least one family study that is completed to identify the rare donors. So to date, they have around 1,25,000 rare donors with 88,000 currently active donors, and they receive around 1,000 requests per year, of which 94% they are able to fulfill. Coming to the Iran Rare Donor Services, the Blood Transfusion Organization, though established in 1974, the Rare Donor Program was initiated in the year 2009. They have a central immunohematology reference laboratory for carrying out these programs, and it caters to 31 blood centers. The good thing about this Rare Donor Program is everything is the cost of all the typing and maintaining the database of rare donors is maintained by the government, and providing the unit is also free of cost for the patient. Coming to Brazil, they have an interesting way of identifying rare donors. They adopted 4 methods to identify rare donors. When we see the first one, they used to screen for K positive, capital K positive individuals. Whenever they saw a capital K positive individuals, those donors were further typed for small k. And if that is negative, so they are considered as small k negative individuals and are taken into their rare donor registry. Next, they looked for donors who are small s negative and capital K negative. These donors were further phenotyped for capital S. And then if both small s and capital S are negative, they were subjected to glycophorin B phenotyping to identify the U negative variants. Similarly, they had for DIA positive and K negative for RHCE phenotyping to identify the rare phenotypes. They had a separate genotyping method called the snapshot, which is not very clear for me, but they identified RH variants using that method. Similarly, to identify the small e, the rare R2 phenotype, they followed E positive, K negative individuals. They were further phenotyped for small e and then identified as R2 if they are negative for the small e. So this was their unique way of identifying rare donors, and it appears cost effective as well and may be adopted by some of the developing countries. So similarly, as I told, they had a identification for RHCE variants and also the HRS and HRB negative units. So based on their program, they could identify from around by serological screening from 4,500 donors, they could identify 12 rare phenotypes. by molecular screening around 11 phenotypes, and the RHD negative rare phenotypes were 6, and the CE variants were around 11. So they could identify a total of 38 rare phenotypes using this method of screening. Now coming to Japan Rare Donor Program, they had two different categories of rare donors. The category 1 is one in which the frequency of the rare phenotype is less than 1 in 100 to 1 in 1000. And category 2 when the prevalence is around 1 in 100 to 1 in 1000. So they had a routine testing for all the 11 antigens, that is the capital C, RH, Duffy B, Kid A, Kid B, Louis A, N, S, and DIA. This is routinely done for all the samples, and in addition, they have their own developed monoclonal antibodies for certain rare phenotypes. So using these, they could identify some of the rare phenotypes in Japan, and they also ship to other countries. Coming to the French Rare Donor Program, here they include both donors as well as the patients into their rare phenotype registry. And they define the rare donor as having a prevalence less than 4 in 1000 or 1 in 250. So they had started almost close to the International Rare Donor Program. The National Rare Donor Database for French was started in 1960, and their rare blood bank was initiated way back in 1980. So they also have two categories of rare blood units. One is with a prevalence of less than 1 in 250, and the other where they are negative for multiple common antigens within the different RH phenotypes. So these were the 10 topmost requested rare phenotypes during their study period, where Duffy null, that is A negative, B negative, was most commonly requested, followed by K negative. So as per their report, they have around 12,929 individuals, which includes both patients and donors listed into their registry. So this is the flowchart given by International Rare Donor Panel for request of rare blood. So it has three sections. One is it begins with the local facility, and then the national registry, and then the international panel. So when there is a need for blood at a local facility, first we need to look into the availability at the local facility or in the family. If it is available, then the blood is made available, collected, and received transfusion. If not, then go to the next level, confirm with your national facility. If not available at the national facility, then we should look at the international rare donor panel. So this, to summarize, this will be the chain of events. Like when the rare phenotype is confirmed, there is a request for search at the national and international laboratories and databases, whether a donor or a frozen unit is available, what is the testing strategy, what are the logistics of importing the unit, the shipment request, and what is the shipping outcome as well. So in a nutshell, like the treating physician, when there is a request for rare phenotype unit for transfusion, the local blood center is requested for the same. Then if not available, the reference laboratory, then the national and the international rare donor program. So what about the costs in all these? In a study done, they have estimated that generally the cost for collecting, testing, and storing is around $925 to $1,150 per unit. And as per the American Rare Donor Program, if there is a special antigen typing, it will increase the cost by another $1,500 to $1,200 per each unit. And so taking both into consideration, it will increase up to $1,150 to $1,373 for importing one unit. Sorry, for making available one unit. Suppose if we need to import it, then another $2,800 might be increased. So it is a very costly process as per the study. So we need a support from government as well as other agencies. So, but what is the problem with this International Rare Donor Program collaboration? Yes, it is good to have collaboration, but are we always able to get the support from them? We have a lot of logistical problems in sending the units overseas, the transportation costs, who will be bearing. There might be disparity in the testing protocols between countries, and there might be differences in methods used for freezing, and who will take the responsibility of the side effects when anything occurs. So there are mainly two main factors to initiate a rare donor program. That is, we need to phenotype. The red cell antigen typing should be done in large cohorts of donors. And also these donors should be enrolled, and even patients who are identified who can become future donors can also be enrolled with these rare donor registries. So now coming to the scenario in India, what is the current practice in India? It is more or less similar, like when we do not have a rare donor program, we always send our samples to the reference laboratories for further workup. Then, meanwhile, simultaneously, cross-match with ABO compatible family donors is also tried. Then in many centers, we also follow the random cross matches. Then we can also apply the PBM strategies, autologous blood donation when the patient is fit for the same. We also use the WhatsApp groups to know if there is any availability of the rare phenotype if it is identified. And we also contact directly the reference laboratories on further management of our patients. So do you think there is a need for rare donor registry in India? So let us see the study. Here we have compiled around 17 studies that have performed extended phenotyping on donors. And few studies have included O group donors, few have included all blood groups, few have phenotyped for RH antigens, few have phenotyped for RH-KEL, few have done almost 18 to 21 blood group antigens. And if you see the sample size, even if you take a cumulative sample size, it is only around 60,000. That means in our entire country, around 60,000, or maybe if any studies are missed, which are done recently, up to 1 lakh individuals are screened for their entire phenotyping. But when we look at the Indian population, it is more than much lower what we have phenotyped. And if you see the comparison zone wise, there was even within India, there is a lot of significant difference between many phenotypes. Hence, there is definitely a need to screen our donors more. We have to do in larger cohorts, and whenever an individual is identified, it is good to report to a reference laboratory as well. So coming to high incidence antigens, this is by Dr. Shanmugh Joshi sir, who has identified way back in 1984 the capital I, small I negative phenotype. They also had reported a rare blood group of Mg blood group antigen in 2 Indian families, the anti-M, which is an antibody against the high incidence antigen, and also the Colton null. Similarly, in this study by Divya Setya et al., they have reported a D negative dash phenotype, 1 small k negative phenotype, and 2 Bombay blood group from their study. And also we have reports of the penal, as we discussed the case what we had. Similarly, there were more cases of the penal that were identified in India. We also had the anti-Gerbich antibody against the Gerbich 2 antigen in 2 cases. We recently had a verbal communication regarding a request for the D dash unit. However, for a lady admitted in Mangalore hospital, though we tried to contact Swati ma'am and Setya et al. For the availability of the donors, the patient was not willing, and we could not support it, but there is a request for the same. So it is not very rare to have rare phenotypes in our country. So these are some of the rare phenotypes, the Bombay being the more common. And coming to the Bombay phenotype, it is the most commonly requested rare blood type in our country. And one of the study has shown that the incidence is around 1 in 7,600 in Mumbai and is 1 in 2,500 in the southwest part of Maharashtra. And the donor patient ratio is 1:4. Though we have a higher number of donors, still the donor patient ratio is quite low. So we need a registry for these rare phenotypes. Coming to alloimmunization and multiple antibodies, in this systematic review, we identified that around 4.8% of the multiply transfused patients had alloantibodies, of which 10% had multiple alloantibodies. So we also have a need for phenotypes which are negative for multiple common antigens. So definitely there is a need for rare donor registry in our country. But what is the challenge or hurdles? We have a lot of hurdles like logistic, technical challenges and administrative challenges, some of which are like most of the blood center services are decentralized in our country. And we all there are varying pre-transfusion practices as well. In some centers, it is done by tube technique, cross match is done by tube technique. Some it is done by column enucleation technology. Some follow antibody screening as a part of pre-transfusion testing. Even this antibody screening, some follow use of O-pooled cells, some follow 3-cell panel. So there are varying practices. We do have reference laboratories, but again, most of the centers have one for serological workup. So the molecular workup is being initiated at some of the reference laboratories now. And we do not have, like the studies what we have seen are all cross-sectional and one-time studies of phenotyping of the donors. We do not have a continuous phenotyping of donors being performed. And also if we have a rare donor registry, how to maintain the website, how to employ staff, how do we perform the search, what is the cost of transportation, what is the cost of additional testings, and if we need to import some frozen RBCs. So what are the shipping and customs requirement? There are differences in infectious disease testing across the countries. And if you look at our donor profile, most of them are one-time donors. So if, at individual center, whether the rare donors contact is being updated regularly or not. And along with all this, if we need to import, we need to adopt to ISBT 128 and also the licensing issues. So these are some of the challenges that I have listed out, but there are many more. Despite all these challenges, the National Rare Donor Program in India has been initiated as a collaborative effort of multiple blood centers at the National Institute of Immunohematology, Mumbai, under the directive of ICMR. So they are coming up with a Rare Donor Registry of India. So these are the centers which are being involved to develop the National Rare Donor Registry, and they have received funding for screening, antibody screening, antigen typing, establishment of indigenous cell panels, development of a National Rare Donor Registry. They have developed a model database for the same and systematic compilation of these rare donors from our entire country. So they also have a coordination committee for the same, for website development to identify centers who can access the database. They're developing an SOP for the rare blood donor request, creating awareness about the rare donors, defining rare donors, preparation of red cell panels, and resolving complex serologies. So this is from Dr. Swati Kulkarni's presentation in 2021, where Madam has told the number of rare phenotypes that are available at their center. That is, they have 15 Parabombay, 2 RH null, 13 D dash phenotype, 3 P null, and 1 phenotype which is negative for capital S, small s, and U phenotype. And they also have a variety of rare RH phenotypes as well. So coming to the transfusion genomic group, they have come in collaboration with many clinical transfusion medicine specialists. They have compiled the profile of blood group genomics of the country. So this is their website where the genomic variants are available, and it is easy for us to identify the variants that we are able to identify. So what are the other registries that are available in India as of now? As I've already discussed, NIH Mumbai has a list of rare donor phenotypes with them. The Sankalp Foundation, which is a non-profit organization, it maintains a list of Bombay blood group donors from Maharashtra. And in their foundation, they have a list of 117 Bombay RHD positive and 16 Bombay RHD negative donors registered. And the rare donor panel in India has been formed under the Asian Association of Transfusion Medicine as well. And the 4 blood centers are part of the program. So now coming to our experience, we conducted a study between 2016 to 19 on identifying rare blood group phenotypes. So over the study period, we had around 23,000 donations that occurred in the population, of which 9,000 were of O group. But as per our inclusion criteria, we have taken that they should be a regular donor and should belong to the local area and to the local, so that they can respond immediately in case of there is a need. So based on that, we could identify around 521 regular donors who were screened based on their protocol. They were screened for around 21 blood group antigens. So we classified our rare donors as those which have a frequency of less than 1% in the population as category 1, and category 2 when they are negative for multiple common antigens with a prevalence less than 1%. So based on this, we could identify in category 1 a list of 8 donors, Bombay being the most common, followed by Lutheran Null and the R2 phenotype and other rare RH phenotypes. And multiple individuals who are negative for multiple common antigens, we had 5 phenotypes who are identified as rare donors. So after identifying them, we provided a red cell antigen card with their extended phenotype, and also took a consent to be a part of our rare donor registry. So this is our website for the rare blood donor registry, where the request for rare blood can be raised, and it also has a list of phenotypes which are available at our list of donor phenotypes which are available, and this is the pro forma for the same. And once a request has been raised, we receive an email notification for the same. So we need to keep some of the clinical aspects in team. It is always a teamwork between the clinical clinician and the transfusion medicine team. We need to discuss in all these phenotypes whether there is a real need for transfusion. The risk versus benefit needs to be established. What is the available time for transfusion? We need to guide the physician properly about clinical significance of the alloantibody and what are the alternatives available for transfusion. To summarize, it all starts with screening, identification, then reference laboratories to identify complex cases, provide an antigen profile card, a rare donor card, maintenance of rare donor databases, regional and national registry. There should be a link between these regional and national registries. We also need to develop some storage facilities for these frozen red cells, and need to have proper SOPs on freezing and thawing process, and a better international collaboration. So to achieve these, we need a cooperation to benefit the patient care between the regions of India. So we need the associations or working party groups to coordinate well in developing these registries. We need more funding for screening donors regularly, managing a database, and to provide facility for freezing and dispensing these rare phenotypes. So this is the roadmap which can be used for acquiring a rare phenotype until alternatives for red cells are available, like the induced pluripotent stem cells, the echo RBCs, stealth RBCs, or the artificial oxygen carriers. But the easiest or more attainable is to increase our rare donors, maintaining a database by doing high throughput DNA based testing, or even a serological method using significantly extended typing of all donors to identify our rare donors. So I would like to acknowledge our HOD, Dr. Shami Shastri, my colleague, Dr. Ganesh, and Dr. Isha, who was doing her thesis on the rare donor registry, and our entire team. Thank you. Any questions? Maya ma'am? Maya ma'am, you are not audible. Maya ma'am, you are muted.
താങ്കൾ വിളിക്കുന്ന നമ്പർ ഇപ്പോൾ തിരക്കിലാണ്.
There is a question, one question in the chat box.
Maya ma'am, you can speak now.
Thank you, Deepika. I was unable to unmute. I'm sorry for that.
Okay,
Thank you,
okay.
Deepika, for the informative session. And you have well explained the challenges that you face in this field. And we are well aware of the difficulty in procuring an antigen negative unit for a high frequency antigen. And this establishing rare donor registry will help all of us to find compatible units. And I think you have done, actually you have a registry there, no? Unfinished
Yes.
3 years back with
Yes,
521 donors, you did one. With 521 donors.
yes, ma'am.
Yes, I understood that from your talk. And I'm happy to tell you that we have also started one rare donor program in our institute also. And
Okay.
it is ongoing, and we have included 2,500 donors, not patient samples as they do in some other countries. But actually, I think that's also nice to check the profile of the patients. Anyway, we are the cost and the challenges. Cost, as you said, it come up to 1,000 per donor, 1,000 per donor or more than that. And even though we haven't completed the program, but still we got some advantage of procuring certain units in such certain occasions. After we have finished about 500, then we were able to help a patient having the with the help of this rare donor registry. And another thing is, it was interesting to hear that in one country, I forgot which country it was, they are doing a cost-effective stepwise manner. Initially, they screen for, I think, because since it is a costly procedure, and the challenges are very high in completing the donor registry, difficult to get donors, and you have done more than 500 samples, I have
Yes,
one question
yes,
for
ma'am.
you, Deepika. And in which platform you did that? Using
We have done on column agglutination technology, ma'am.
column agglomeration technology.
Using anti-sera provided by Biorad.
Machine you were using? Which machine? Which machine?
Not on the machine, ma'am. It was done by semi-automation.
Okay. And you
Yes.
got use the patient's
Anti-sera.
sera
Rare
also for
anti-sera.
typing. Okay.
Yes, ma'am.
That's-
And all the antigens were screened at a time for each donor. Like they were
Okay.
screened, we have not followed any stepwise manner as I have discussed in one of the study, but we have phenotyped the entire antigens for every donor at a single go.
That is economical, but I think that is little more difficult
Yes,
to
yes.
plan and all for the first step and the second step.
Mhm.
Anyway, it was a nice experience to share with you.
Okay,
And
ma'am.
any questions from the participants?
Dr. Deepika, Dr. Abhishek here.
Yes, sir. Yes, sir.
Yeah, very nice work Manipal has been doing. Congratulations for the entire team.
Yes, thank you, sir.
Just one doubt. I did not hear properly. Have you identified 521 rare donors?
No,
Or
no, no, sir.
521
521 donors were
people?
screened.
Yeah, okay. And how many of them were really of a phenotype which can be really considered as a...
Single antigen negative were around 8 phenotypes, sir.
Mhm.
And multiple common antigen, negative for multiple common antigens were 5, if I'm not wrong.
5. So that makes around 13 out of 521,
Yes,
correct?
yes, sir.
Okay, so that is the challenge that everybody will face.
Yes,
It's a
sir.
huge exercise before we actually get into the ones which will really make a difference with respect to the rare donor is concerned.
Yes, sir. This is all by chance what we are
Yes, exactly.
screening.
Exactly. And even the ones in we identified, the loss to this one is so much that either due to migration, disease, or lot of other things.
Yes.
Really, it's a challenge. But yeah, of course, they say Rome was not built in a day, so we have to take the small steps and hope it's a good initiative. Hope more and more players in the sense the corporate as well as the NGOs pitch in so that we can integrate the things around. Only then it can be fruitful.
Yes,
because
yes,
with small numbers it's really difficult because and that too we are talking about all phenotypes 8, like particularly if you are looking at things that we need, that may be very difficult to get.
Yes, sir.
So is this funded by somebody or?
Yes, sir. Biorad had funded.
Okay, fine. Okay.
Otherwise, it is very difficult to have
Yeah,
these rare
exactly.
antiseras only, sir. They are very
See, the most
costly.
important thing is, I don't know, I feel when we come across an antibody and we, like as a case-to-case basis, look for an antigen negative blood, no?
Yes.
See, these things has to be, even if we screen a unit of blood for any antigen, we have to record it and keep the data so that over the time it builds up.
Yes,
That
sir.
is also one way of doing it.
Sir, actually, we do that at our center where we tag the
No, that is what I meant. Not just one center, every
yes,
center
they
should
should
do
be
that.
pooled, sir.
Only
They should
then,
be pooled.
yeah, only then we can maybe 10 years from now or probably 15 years from now, Yeah, India can really have a good self-sufficient rare donor registry.
Yes, sir.
And it has to be continuous because obviously the the donor population keeps aging and lost over the pool.
And they might change their place of living, everything. They might
Yeah,
not be
even change of
available
the place,
immediately.
there should be some amount of networking that the donor goes to new place. We have to link him to somewhere nearest blood bank so that
Yes.
he still continues to somehow be the part of our registry. Thank you, Dr. Deepika. Thank you.
Yes,
Thank you, madam.
thank you, sir. Thank you.
Good afternoon, Deepika. This is Dr. Mohan.
Yes, sir. Good afternoon, sir.
A very nice presentation.
Thank
Deepika,
you, sir.
is there any alternate technology for doing mass screening for identifying rare donors other than our conventional antiserum? Any center has been trying in India? Because in West we have heard about this genotyping, which is they say it is claimed to be cost effective.
Yes,
And there
sir.
are some publications saying flow cytometry can also be used for mass screening, which appears to be cost effective than our conventional screening.
Yes,
So,
sir.
any centers in India, you have any ideas?
I'm not very sure, sir, but NIH Mumbai, the madam has presented in her session that they can follow high throughput genotyping, but I'm not very sure whether it is being done or not.
Okay. And one more thing, like for all these donors, upfront you do DAT and IAT and exclude them before
Yes.
including them.
Yes, yes, sir. Because DAT, it may lead to false positive, serology positive, because some of the antiserums we need to do in HG phase.
Okay.
So we cannot determine the phenotype in such case. So we have excluded them from the study.
Now, are you continuing the registry?
No, sir. Registry is being continued, but phenotyping is not being done. Like whenever we have new donors, like Bombay positive or Bombay negative, we are including them into our registry, sir.
Okay. And one more thing, on Bombay donors, are you doing minor phenotyping?
During the study period, we have done, sir, but not now.
Because there are few cases where Bombay patients developing allo antibodies. So
Yes, sir.
if you have access for like a source for typing them, it will be very helpful because you had some 4 Bombay donors, right?
Yes, sir. Those 4 entire phenotyping is done, but not for others who were identified later.
Do you store these samples? Cryopreserve these samples for further phenotyping later stage?
Of the donor unit, sir.
Yeah, no, in the sense aliquots. Or aliquots? No.
We have phenotyped almost 21 blood group antigens, sir.
No, no.
Okay, in case we need any other.
In case it's a random sample coming, so you type then and there and finish it off, or you store them.
We do not store them, sir. We have not stored them. We have done immediately.
So,
and following which we advised the donor that he is a rare phenotype and may donate only when needed.
And when the patient is requested for this rare donors, whether these donors will be confirmed again for the antigen presence or like rare antigens patterns, are we confirming? Is there any protocol like that?
So now we have not developed any, sir, but we can do that.
Because like when we are mass screening, so there can be some typographical errors.
True, sir.
So
it is better to confirm the phenotype again.
At the time of like how we do for a Maradona registry, parallelly such a like we have to devise some mechanism so that the registry serves the purpose correctly.
Yes, sir. We have used for the R2R2 phenotype only, sir, till now. And we did not recheck the phenotype and it was compatible for the patient.
I think it would be a double exercise phenotyping. My suggestion is just do a IHG cross match, and if at all something is I mean, incompatible,
Positive.
maybe we can repeat it. Otherwise, will be, I mean, it's really a hectic and a,
No, not all the
Not
donors.
for the
No,
entire
not for all the donors.
Sir
The
is
donor
suggesting
unit
at least for the
person
antibiotic.
where the request has come and where the donor is available, such a donor alone has to be reconfirmed before issuing the product. Maybe that's how it is done in the stem cell transplanting setting. Maybe rare donor registry can also look in that angle.
Yes, sir. At least a cross match before that will be helpful.
cross match anyway we are going to do, so that's not an issue.
No, before collecting the unit, sir.
Yeah, first cross match and then collect. Yeah,
Yes,
that's
yes.
not a. But donor may not be available in the same place, no?
True, sir. That's why
Like,
there are a lot of challenges, sir.
No, that's why I asked you if there is any option for you to cryopreserve this, like store glycerize the samples, donor samples after finding them like rare donors. Is there any option for like storing the samples?
We
And-
have rectal preservative solutions are available for preserving this red cell samples. But
We
that
can
depends.
have it, sir, actually. That is also a good thought. We can have a preserved sample, and if we need to phenotype for some other antigen also, we can actually do that.
For cross matching, we can cross match with the donor sample, the
Yes, sir.
clinical sample, so that once it is compatible, then we can
Then
tell
we
the
can
donor,
call the
between the
donor.
donor, the donor. Like it's a tedious exercise, but in the long run,
Yes, sir. It will be helpful.
Deepika,
Yes, ma'am.
Deepika, I have one comment.
Yes,
It
ma'am.
is even though this is a rare donor program has many advantages, so many disadvantages are also with this program. Challenges are high, cost, and as Dr. Abhishek said, the donor pool is not a constant one. No, when they over the time these donors won't be available, even though they sign on the consent form. Whatever they do, they won't be available. Actually, we face such a difficulty in starting the rare donor program. So many donors were enrolled initially, and there were very few turned at the time of starting the program. So you collected the samples whenever you get that O group donors, and you started doing. I think that will work to some extent. But later, even though they are they are from the same locality, or even though they are regular donors and all, the availability is uncertain. Is it not? Availability is quite uncertain. And the concept of rare donor program is very good, but challenges are very high. And 100% success with this program, I don't think that will work. To some extent, it will be helpful. I think only to that extent. The next level you said in your presentation, and that will be the solution for tomorrow's ideal solution for tomorrow.
Yes.
Okay, thank you.
Okay, ma'am. Thank you. Thank you so much.
Thank you, Dr. Deepika ma'am, for the wonderful session. Thank you, Dr. Maya ma'am, for chairing the session. Thank you all for joining us today for this insightful webinar. We hope you gained valuable knowledge. Until next time, goodbye.
Thank you.
Yeah. Thank you.
Thank you.